Ladies and gentlemen, let me introduce you to Dr. Robert Walters, trustee Orbis organization, and I think your plane is parked in the center of the room. And Dr. Christopher Ben, senior advisor of the Global Fund. Before we get into the question, I'd like both of you in very short couple of minutes to explain the organization you're running or working for and how it adapts to the issue of remote areas. Please.
Okay, is this one working? Yeah. Hi, so yes, I'm Rob Walters from Orbis, and I welcome all of you. Thank you so much for joining this debate, and I hope that it'll be a lively and active debate. Don't be afraid of asking difficult questions. Orbis is an international NGO. We are dedicated to the treatment and prevention of eye disease throughout the world, but particularly in developing countries. The scale of the problem is very substantial. There are in the region of 37 million people who are blind in the world, and those are people who cannot work, cannot learn, cannot really live a full life. And in all, there are about over 250 million people who are blind or visually disabled, and those are the people who really cannot contribute to their societies and whose life is very much unfulfilled. So there's a big job for us to do. Orbis is one of the big 5 NGOs involved in eye health in the world, and last year we treated in the region of 6 million people, and we screened over the last 2 years over 4.2 million children in developing countries. We work in a relatively small number of countries in the world, concentrated in sub-Saharan Africa and in Asia and to an extent in South America. And our strategy is to work in depth for a long period of time in a country with them. So we work very much within the health systems of that country in order to try to achieve their health goals as far as eyes are concerned. Thank you.
Thank you. I think if you look at the big picture of global health, there is indeed hardly any other question that is more relevant and more challenging than this one. How do we reach the kind of people in the remotest parts of the world? And I will tell you why. The Global Fund was created in 2001, so right after the launch of the Millennium Development Goals. And the mandate was to fight against the 3 major infectious diseases, AIDS, tuberculosis, and malaria. And we made huge progress, over the 15 years until 2015. Incidence, mortality by AIDS, tuberculosis, malaria has gone down 30, 40, in many countries 50 and 60%. So it's huge. But now the new mandate is, as part of the Sustainable Development Goals, to end AIDS, tuberculosis, and malaria as epidemics by 2030. And to reach that, this is the most difficult question. We reached probably in the first 15 years those who were relatively easy to reach. And now we have to talk about how do we reach those in, geographically remote areas, but not only geographically. It can be in urban slums. It can be marginalized populations. It can be migrants. It can be, people who are marginalized, criminalized in many different ways. And that's the main question that we have to address. And I'm wearing today 2 hats, actually, for the Global Fund, but also for another organization that is mainly engaged in promoting digital health. And if you're asking me the right question later on, I'm happy to share my views on how digital health can help us to reach the people in the remotest areas.
Let's start with that. Most people outside the realm of health think technology will revolutionize everything, and with technology, ultrasound, digital phones will basically be able to treat anyone in the world, whether they're 1 hour or 10 hours from any city center or hospital center. Is this true, or are we just daydreaming, basically?
I would say it's partly true. And it really needs what is a very interesting combination. Because as the Global Fund, we're operating in 120 countries around the world. All countries in Africa, Asia, Latin America, Eastern Europe, and so on. And it's not just the solutions to end AIDS, tuberculosis, malaria is not just technical and technological. You need community health workers. You have to have people who work in the remotest areas. How do you provide incentives for them to do so? How do you train community health workers? That's really kind of simple, adapted technology. But the new technologies, through cell phones, through drones, through many modern technologies, telemedicine, they offer now, in addition to that, huge, probably revolutionary opportunities to reach people who otherwise, are extremely hard to reach. So I think we are really looking at a very exciting time in global health, for the next couple of years in terms of how we can reach the people in the remotest areas.
Dr. Walters, on the technology issue, how do you use technology in your own organization?
Technology is where it's at the moment, and this is where it's going to a very large extent. We have Cybersight, which is a telemedicine portal, with whom we can reach, as has just been said by Christoph here, the majority of the people we can reach. And this is largely because of the gargantuan growth in cell phones. Whichever poor country you go to, anywhere in the world, you will find that the vast majority of people have got cell phones, and that's the way you can connect with them. Wi-Fi, different issue altogether. So cell phones are the thing where it's at, and Cybersight does exactly that. So we can, and that's in terms of diagnosis, reaching people, informatics, actually informing them about issues, and also in actually directing people to come to the places where they can be treated. I think we need to differentiate between the various conditions we're looking at. We're identifying these people, we can communicate with these people, we can diagnose these people to a very great extent with information technology. But you then have to get those people from remote areas to a place where they can be treated, so that there is much more to it than meets the eye. And just to take your point, Christoph, which I thought was a good one, is that it's not all about technology. We need to remember that we are dealing with people and we're dealing with communities, and you have to reach out to that communities as communities using every single opportunity that's available to you. For example, there was some research carried out in South Africa, which we worked on and which we capitalized on, which was the evidence that remote populations, poverty-stricken populations, trust their traditional healers more than they necessarily trust these sophisticated NGOs who come in, or their high-tech hospitals close by. And if you bypass those traditional healers, you lose the trust of your organization, of the community. And therefore, we did some work in South Africa where we actually engaged with those traditional healers to meet and to reach out to those people in poverty-stricken areas, and that was immensely successful.
You both discussed about the healthcare workers, which seems to be a crucial element of any policy. There was a lot of very interesting stories, if you go on the net, about the space station and how one of the astronauts becomes basically a health worker, because it's pretty difficult to shift an astronaut back to Earth if there is any medical emergency. They call that task shifting. How can we hire, professionalize, format those professional health workers?
I'll answer it briefly and I'll give it to you, Christoph. I think that community health workers are vital. They are part of their community. They are already accepted as being leaders, if you like, of their community on their health side. They are receptive. They're intelligent. They want to be trained about the issues that we wish to train them about. And they will then engage with their populations and act as a conduit to them. So from my point of view, they are completely vital. And they are... This is not expensive technology, but this is very inexpensive but very vital to bringing communities to us.
Yeah, I think it's exactly what we are saying. You need both. You need really kind of people who engage with people, community health workers or other professionals, but you have to enable them to do their job, and that is the important question. And I think one key word here is leapfrogging. The question that even in the remotest, even in the poorest countries and regions, they are leapfrogging, stages of technological evolution. And let me give you one example. I mean, I started 30 years ago as a physician working in a remote hospital in Tanzania. One of these places we are talking about. Hospital serving a whole district. No kind of permanent electricity, no telephone line, nothing in terms of technology, only the most basic drugs. And by leapfrogging, what do we mean? Now, energy supply is decentralized, right? You still are not connected to the electricity grid, but you have solar power. It's decentralizing, it's almost democratizing energy supply. Telephone line, still no telephone line in that hospital, but everybody has a cell phone, and the connectivity is good. Financial transfers, nobody had a bank account at that time. They still don't have a bank account. They will never have a bank account because they don't need to. They do all their financial transfers through cell phones. So that's what we mean by leapfrogging technologies. But how is that related to the kind of what we want to achieve, to bring healthcare services to the people? It's very closely related to that. Even in those areas, working with community health workers, you're sometimes applying pretty sophisticated technology. As a Global Fund, we use GPS technology, geomapping, to make sure that we bring the drugs and the mosquito nets exactly to the remotest communities. In some places like Rwanda, there's even now, services delivered by drones. Very essential goods can be delivered by drones, for which you needed trucks, on dirt roads before. But probably the most revolutionary is the cell phone technology that is spreading so fast in Africa. You can now pay these community health workers by cell phones. There's no kind of financial transfer. There's no cash transfer anymore. We can use the cell phones, and these community health workers get paid. And that's a big incentive to stay in the remote areas. And also, the organization I'm engaged with, the Job Lange Institute and Farm Access Foundation, they've developed a kind of what they call health wallet. People have, on their cell phone, a mechanism they can receive and spend money on health through their cell phones. And that's revolutionizing how you finance health services. So these are the opportunities, I think, that we see.
Both of you are representing very powerful NGOs, multilateral funds. Is there any way we can work to increase the capacities of the states? And I'm speaking basically on the developing world, because at the end, what we want is self-efficient states which are able to provide most of that remote health opportunities. Do you think that there are progress, or do you are working closely hand by hand with the states? How does it work?
Okay, fine. Thank you, Christophe. Absolutely. I mean, this is fundamental to working in developing countries anyway. In fact, working in any country as an NGO, the very first thing you need to do is to engage with governments. You must engage with governments. You must lobby governments. You must say, we want to change your healthcare systems because we think this is what will be better for your population. I mean, I also think that NGOs engage with governments and with countries with an open mind. I mean, we learn a great deal from governments. They know about their epidemiology. They know about their countries. And so it is very important to work hand in glove. Can you make a difference? Absolutely, you can make a difference. I think that the advocacy, the engaging with them to demonstrate effective and inexpensive treatments for your particular sector, whatever it may be, is vital. And I think pointing out very important issues, such as the economic empowerment that removing health obstacles can give to that nation is very important. And also it's very important to make those points to your donors who are giving your money and saying, well, more and more these days they want to know what their return on investment is, and that's perfectly reasonable. And therefore we need to say, yes, we've done this. And I think that there's been great evidence that in many, many instances, in AIDS, for example, that a huge difference has been made to nations and to nation system. And in our particular case, with trachoma, we are finding a gargantuan difference in Ethiopia and other countries. Ethiopia is the biggest country in the world from the point of view of concentration of trachoma. Huge difference. So very much so. Thank you.
And I would answer absolutely yes, but... Yes, the Global Fund obviously works wherever possible with governments. A sustainable health system you cannot run without a government. And that's, I would say what is happening in 90% of the countries we operate. But in this session, the remote areas, we're also talking about providing services in fragile states, in states afflicted by conflict. We had a great session yesterday here at the WISH Summit, on these situations. That's the challenge. That's the biggest challenge. And there sometimes you simply cannot work with the government because either government doesn't exist or doesn't have control about the whole country. So the Global Fund, has been running programs in countries like South Sudan, like Yemen, like Central African Republic. Syria is one example. And then you have to approach it differently. Yes, you try to work wherever possible with the government, but you cannot say we give up, to provide services because the government doesn't exist or doesn't have control. Then you have to find other solutions. We do work then with non-governmental organizations. We do with kind of regional, governments maybe. Take DRC Congo. Many regions of that country central government has no control, so we work with the local governments, if you like. And that's, again, where technology comes in. The new technology, in a sense, allows you sometimes to access, regions that are not under the monopoly, if you like, of governments before. Before, governments had monopoly on energy, on telecommunications, and so on. And those have been broken up. And the technology allows you more than before also to work in really difficult regions. Sometimes it's also geographical. Rainy seasons, many regions are difficult to reach, and with modern technology, you can still reach them. So I think, absolutely, yes, we need governments, but we need also to think, how do we, provide services in fragile countries, in countries in conflict?
Thank you. We mostly talk about the emerging world, developing world, but when you read around, you discover that there are also issues of remote health facilities in the rich world. I read stories about America, Australia, some part of Europe. Are we talking the same thing or a totally different, or is this totally different issues?
I start, and Robin, then you continue. Now, the issues are often the same. Obviously, the health systems look differently. But we are getting into a situation where more and more, I think, also the rich countries can learn from the technology that is first applied in, poorer countries. Take this cell phone technology that we are talking about. Take the geo-mapping and other, initiatives that are very essential in some countries, but in countries like Australia, with a vast territory, you might, apply some of that as well. The cell phone-based technology and how to link that to the health insurance systems, that's probably something that the US and other countries, can learn, because not everybody has health insurance there. How do you make sure that there's a kind of prepayment scheme for health? So in a sense that opens more opportunities of learning from each other than before.
Thank you, and that's so true. I think there's another issue, and it's an extremely good point, that in remote areas, rural areas, wherever you are in the world, in the UK, in the US, you will always find it more difficult to recruit good paramedical staff to go to remote areas. They won't do it. They always like to go to the cities. They like to go where they believe there's more opportunity, better education for their children, better support for their families, and so on. So you're absolutely right. It is not unique to underdeveloped and very poor countries. And I think an adjunct to that is that that in the remoter the country, the remoter the area, the poorer the area, the more likely you are to find that good people, whether they're doctors, paramedics, or community health workers, will leave. And so a big point for us is to try to ensure that they are incentivized to stay, in whatever way that will be. And that can be a big, big question.
One last question before we move to the room. You said that remote areas might be not that far, and I'm thinking about conflict areas, which I think are civil wars or war zones. I mean, how can your experience can be applied to extreme situation like that, or are we back to basic humanitarian job, or is there any difference?
Well, we were having this discussion before, which is how do you define a remote area? And of course, a conflict zone becomes perforce a remote area because you cannot access it, and they are very difficult. And there are some NGOs who specialize and who are able to overcome those very difficult problems. I think the most difficult problem is always security. You have to have a situation where you are sending people in, or you're engaging with the government to send, or the local government send people in. And if those people are going to go in and they're not secure, then it's extremely difficult. So you have to have security to start with. And then within that, I think there is much you can do. But this is a general point, which is you have to do it in partnership. I don't think any of us can do it alone, and therefore we need a lot of coordination. And I think one of the examples that happened in Haiti, for example, and there may be here who are people from Haiti or were engaged in Haiti, was that it was a disaster zone that became an NGO disaster zone because there was no coordination. And but conflict zone is a very special case.
Indeed, let's talk about this region. Before the Syrian war, the Global Fund was supporting national programs in Iraq, in Syria, in Yemen, Palestine territories, Jordan. Now, it doesn't make sense, in many of these countries to have national programs through the governments anymore. So what we changed was we said it's now a people-centered program. We still care for the people, but people are often on the move. So we are talking mainly about tuberculosis here, by the way. It's a major problem in this region as in many other regions. So we are saying if we have diagnosed a person with tuberculosis and you have to make sure that they get treatment over many months, we follow the patient wherever they go. And if they are on the move and they will settle in Lebanon or in Jordan, Lebanon was not eligible for Global Fund, but now it is, because if you follow a people-centered approach, you follow wherever the people are and you try to provide the services. And it doesn't depend now on the government anymore. We call it now a Middle East response because it is a regional program, and we try to, get in touch with the people wherever they need these services. It can be local NGOs. It can be a particular group that is in charge of that region. And then you follow the people to make sure that they have the right diagnosis, care, and treatment. That's a different approach from national government-led approaches that we also pursued in this region.
Thank you. We'll move to the room. Basic ground rules, short question, introduce yourself, and please start with the lady there. Yes.
Thank you. Yes, I'm Dr. Mais. I'm a pediatrician. I'm from Syria. I was working in Aleppo city, and I witnessed the emergence of the poliomyelitis outbreak there on 2013. And I would like to just to provide a very short explanation about how to make the control remotely, any system, very successful system for health. I was reporting about zero report every day about poliomyelitis cases from Aleppo through Facebook, for example. I was just sending zero number for my supervisor in Turkey. And after that, I came in the central body for this program. We are running this system for 4 years with very high level of evaluation by CDC and WHO, and all of that was remotely. We are covering areas of 9 million people in north of Syria. We could make the surveillance system for communicable disease, malnutrition, water assessment, accessibility to safe water for 9 million people in north of Syria. We depend on the technology, and it was very helpful. I could follow the work of the team through, for example, applications like timestamp application. I could know they can send photos with date and time, and I can follow their work. I can follow the cases, the date of the onset of the disease, and the follow-up after 15 days or 60 days. Just I want to give a brief about our successful story about this system, and we would like, if there's any initiative we can provide our experience how to make remote management for surveillance system, communicable disease in conflict countries. Thank you.
Thank you. As I say, thank you for your statement. And as you know, you can reach those two gentlemen around here. So if you have projects, questions, ideas, please reach directly to them.
By the way, it's a very good example of a use of cell phone technology for data collection and data management, which we hadn't discussed. So it's a very good example for how this can be used, whether it's polio eradication or addressing other diseases. Thank you for that.
Thank you very much. I'm Hannah Fall. I'm interested in eye health, but I'm very patient and family-centered. My question to the panel, if we switch this question to how can innovation overcome the barriers of demanding healthcare in remote areas?
Go.
We're always talking about providing to.
Okay.
How can innovation overcome the barriers of demanding
Okay.
the healthcare? Thank you.
Can I clarify that a little bit, Hannah, if I may? Are you meaning that how can technology determine the demand that is in existence, or how can it promote people to make the demands that they wish?
How can both? How can it promote? What innovation can be provided to the people to enable them demand
Yes.
the healthcare and be part
Yes. Well,
of
it's a very good
providing
point.
that to themselves?
Power to the people.
Exactly.
Yes, absolutely. I mean, it's an extremely good point. And I think if we want to talk purely about technology, then I think the issues that have already been discussed and very eloquently demonstrated here, which is that if you have someone on the ground, or even if you don't have someone on the ground, if they can communicate with you in some sort of way what it is that the healthcare demands are of that region, of that population, of that village, then we know about it. And I think that as far as voicing their demands are concerned, that's very important. Equally, in order to present them with the opportunity of finding out what those demands are, for example, in my own case, diagnosing cataract within their village, then I think cell phones and technology, the sorts of technology which are being developed all the time for diagnosis, are ubiquitous. They are becoming ubiquitous. So that is very powerful. I think in a minute, one of the things that I would like to gauge questions on is it's fine for diagnosis. These forms of technology are good for diagnosis. They are good for data collection. They're good for research. They're good for gauging and communication and gauging demand. But at the end of the day, you have to treat these people. You have to get these people from a remote area to an area where they can be treated, or you take the treatment to them. And that's perhaps in a minute we can talk a little bit about that.
I want to give you one concrete example. You know, this cell phone technology system that I talked about, we tested them particularly with very poor, particularly women in Nairobi. And, when they got through their cell phones, they received money on their cell phones, and they could, with that, go to accredited health centers to receive, care and treatment. It improved the demand side. For the first time, they also said we are treated with dignity, in the health, facilities, because we can go and, it's prepaid and we are taken seriously. And the level of, demand, how many services they kind of were asking for themselves and for their children, increased significantly. So you can indeed, I think, increase the demand through this technology. And it's particularly often the most marginalized populations, these really very poor women who otherwise, had hardly any access to the formal healthcare system. So I think there's a lot of opportunity.
This side of the room has been...
Thank you very much. Thank you very much. My name is Dr. Hayat Khojali, and I'm a public health specialist. I think one of the big challenges for us in public health is human resource in general, and how to sustain a human resource. And when it's come to the medical cadre or healthcare worker in general, that's a disaster, especially when it's in a remote area. So how to sustain? I was just interesting to know more innovation ways just to sustain or to retention how healthcare workers in their place. And when it's come to remote, it's more even. We all very like to go to cities, and we are really attracted by the cities with all the other issues. So how can you put a person there or keep them in the remote area, bringing or providing the healthcare? Thank you.
Is your question related? Yes, can you?
Hi, I'm Randy Diamond. I'm a palliative care physician from the U.S., and I also do palliative care work in rural Uganda. And the question that I have tied into that is, in terms of sustaining healthcare workers in rural areas, how we can provide, how can technology help us to provide continuing medical education to those health workers and support to those health workers to help sustain them in their isolated environments?
I see that there seems to be a real issue in terms of practical
And indeed, I have been in that situation when I was working in a remote hospital in Tanzania, how to attract, but even more importantly, how to maintain, health professionals in that setting 8 hours from the capital. And I would say there were two elements. I mean, of course, you need to provide, salaries, housing, transport, whatever, to make it a bit more attractive to work in the rural areas. But I think even more important sometimes is what can you provide so that there is job satisfaction? That they feel they can do their job in these remote areas. Do they have the drugs? Do they have the means? And that's, I think, where also this technology now offers new opportunities. I don't want to speak for you, but I learned from your colleagues the kind of the telemedicine, the kind of training that you can do remotely now. You don't have to go to the kind of university city, and get education. You can do some of that remotely. So I think if we can improve the working conditions, that will help. It's not solving all the problems. I know it's still hard to work in remote rural areas, but it's getting better, I think, and you have more incentives nowadays than you had a couple of years ago.
Thank you, and all that is very true, and these are very pertinent questions. I think as far as education and keeping people up to date and diagnosis, then telehealth, in our case cybersight, is exactly where it's at. But these are very human issues, and I think that for people who are working in very remote areas under very difficult conditions, job satisfaction is very important. They need to remain inspired. You need to be inspired to go to these places. And I think that I've seen many health workers of all grades and understanding lose that inspiration because they don't have the support they require. They want to do a good diagnosis. They want to do a good treatment. They want to succeed in that cataract surgery, but they don't have the resources to do it. And that actually is where we can do it. We actually, all of us in this room, all of us in this whole debate in WISH, can provide that support at a very basic level. And we are talking about simple things here in general. And it is about money, but it's often about inspiration, about motivation, about identifying with those people and being with them and making them feel less isolated than they do otherwise. So I think that's extreme. And so it boils down to human factors as well as financial and material factors that will really make a difference. And I think that sometimes you need to take... you can't always expect the rural areas to come to you. You need to take the medicine, the facilities to them, and that's maybe where mobile clinics come in and so on, hub-and-spoke systems, which many people will be familiar with. But this issue of trying to keep people who are wonderful people in those areas is really, really difficult.
The gentleman, one gentleman, and then I go to you.
Hi, my name's Steve Moore. I'm a primary healthcare consultant based here in Qatar. But my question to the panel is, NGOs have had a lot of bad stick recently around safeguarding issues and abuse issues in areas where they work. So as much as there's innovation and we're talking about, workforce, how does the leadership and management of NGOs ensure that you're delivering safe care and there's no abuse in the system?
Well, it's an excellent question, and it's a very topical question, and thank you for asking it. NGOs need transparent, hard governance from top to bottom. And transparency is extremely important. To try and hide something that has gone wrong is a huge mistake. You need to own up to it, deal with it, and make sure it doesn't happen again. But more important than that, you need to have the standards set for all the people that work with you, from top to bottom, to make sure that they know that those are red lines, you don't cross that line. It is a very important question. People are human. They make mistakes. They err. Some people are better than others. But it's been very damaging to NGOs. So NGOs have a duty of care to the people they are providing the care for, but they also have a duty of care to their own staff, and they need to make sure that those rules are very carefully set. It goes one beyond that. The people who are funding us, the governments, the individuals, the corporations who are funding us, need to make those demands as well. And for example, when an Orbis was asked to apply for a grant from DFID, a big grant, I was very respectful of this. I thought it was a very good thing to do. They came to us and they said, we're going to rigorously look at your organization. We're going to ask difficult questions. And we want to go through you with a fine-tooth comb and find out if you're up to scratch. So that was good. I was very pleased with that. And they didn't. And there were things that they said to us, that's okay, that's okay. We'd like you to do some more with that. That was really helpful to us because being looked at externally is important. So it's not just about what we do, it's about what our masters are telling us to do and are overseeing us. But it is, on the ground, it is up to us to deliver.
Yeah, it is a very important question. I mean, the Global Fund works probably with thousands of NGOs, the big, well-known international NGOs, but mainly lots of local NGOs. And without them, we couldn't do our job. We wouldn't reach the people. And accountability has always been a very important topic, but we thought of that mainly in terms of financial accountability until recently. Have the right systems to make sure that no money is misused and that you deliver against, results achieved and so on. That was the focus. And yes, we now had to learn and adapt, if you like, our whole accountability system so that it does include, human behavior, even if we are funding an NGO and we are not directly responsible for the NGO, but it goes back. I mean, including to the donors. There's no excuse if they know you're funding them, you are held accountable. So we had to strengthen this whole system against, sexual harassment, in the field. But that was a learning exercise. We're all learning all the time, how to adapt our system to manage better.
Thank you. The lady here.
Hi, my name's Elizabeth. I'm a doctor from London and I also work for Right for Education. So my question is, from my limited experience, there's lots of really interesting, exciting new technology, mobile health technology, that's making the global health community better and better at reaching people. But I worry, even with our work, that it's the same 90%, 80% of people that we were reaching before, and now we're just reaching them better. And that final 5-10% who are most difficult to reach, possibly they don't have smartphones, they're not being reached, you can't get the plane near them, you can't do those things. And I just kind of wondered if you thought about that and whether you have any examples of innovations that you think are really helping to reach those people who are most difficult to reach.
The ultra-remote areas.
That's exactly what, I would dispute. I think it's those 10% that are probably going to benefit the most from this technology. Maybe not the 90%, but the 75% of the population, they could be reached, even through the conventional services. I think it's the poorest, it's the most marginalized, it's the ones in the remotest areas that will benefit the most from the new technology. I'm not saying already, but that's, going to work. And just one example again, I talked about this kind of program in Kenya called Mtiba. They don't even have to own a cell phone. 5 or 10 women can share one cell phone. All the information and the entitlement to the health services is on their SIM card. And even the poorest women there could afford the SIM card, and then they share one simple, not even smartphone among each other. So that's one example where I think the technology is getting much more accessible. And you're not talking about the most sophisticated technology here that can make a difference.
Those women were in Nairobi, though. They weren't in rural
No,
Kenya.
yeah. I mean, I talked about Nairobi, but we're talking about a countrywide program. It's in many regions. Kisumu is another kind of region where this is already widespread. So, no, it's... I'm aware, and I know the rural areas in East Africa.
Yes, it's a difficult question. I think I'll turn it on its head a little bit, if I may, and say that NGOs are not... or governments, NGOs, health providing facilities, whatever it may be, it's not all about us giving to them, but it's about empowering and enabling populations to do it for themselves. And they actually, some of the onus has to be on the communities themselves. They have to rise to the occasion. And I think the word spreads. It is like putting a pebble in the pond, and the word does spread. And if you're doing a good job, and people, even in the remotest areas, will be able to will realise, yes, there's something to be gained for that, for my family, for my children, for my mother, whatever it may be, and I will make the effort to do it. It is much more difficult for them, I recognise as well.
I'll take 2 last questions. The lady here. And the gentleman there. Lady first.
Hi, my name is Al-Bandari Al-Khatar. I'm a biological sciences student at Carnegie Mellon University. So my question is regarding specifically the poor rural areas, right? Like the ones where people don't have access to proper education, like they probably don't know much about healthcare. And so how would they be sure that the symptoms they're presenting is actually of a disease? And then this also goes back to demanding healthcare. Like, are there any innovations to kind of provide knowledge about healthcare rather than just the healthcare?
Well, I'll answer that, and I'm sure Christoph will have an answer as well. I think that there is a great deal of IT opportunities for doing just that in education at all levels, and in enabling people to self-diagnose and to reach out to the treatment they require. I mean, many of the cell phone technology that is readily available will allow you to, in my terms, to test your vision, to test your child's vision, to make sure they can see, etc., and to diagnose a cataract in your grandmother or indeed in yourself in the mirror. But and many other conditions. So I think that technology is very much an opportunity for diagnosis and for showing people how to perhaps treat themselves or to take themselves to treatment.
Again, a very important point, and I think we are talking here now also about the link between the health and the education system. It's not just the health system. Education and health are very, very closely linked, and particularly when it comes to that, that people might even be aware of diseases or symptoms and so on. It's not just the health system. So we're also talking about how we can improve primary education, provide that in the remotest areas. And again, technology will provide some advantages here. And I'm not pretending that every kind of primary school student will have a cell phone or a smartphone, and I'm not naive. There will always be people that are still very hard to reach, don't get me wrong. But even there, I think in terms of teachers' education, including teachers' education on health issues, there has been a lot of progress, to provide them with better education, and we need that if we want to achieve the health goals.
You have the last question, so it's a huge responsibility.
A lot of pressure. I'm up to it.
Yes.
Thank you for this panel. It's been very interesting. My name's Dave Barrett. I'm a professor at the Ivy Business School in Canada. So I'm going to come at this from a little bit more of a business lens. Is like provisioning products and services is not unique to healthcare when it comes to remote areas. Who do you guys look to as kind of leaders in logistics, distribution, and provisioning in other industries that you can take what they already do well and apply it in healthcare?
Excellent question.
I can give you, again, concrete examples. I talked about, GPS and geomapping that we're using to provide the best, supply chain and logistics services. In some of the poorest countries in the world, we learned it from Coca-Cola. We have a big program with Coca-Cola and a number of other companies, and actually USAID, so that they provide their expertise and skills and technology. Not that they do the distribution, but that they share how they do the distribution. And we do that with Unilever, we do that with some of the big companies, just to share their technology to do the kind of procurement, supply chain management much better. This is just one example. Yes, we are looking very much also at the business sector. What can we learn from them? Because that's something they do pretty well.
Yes, and of course that's absolutely true. And before I did medicine, I worked for Procter & Gamble, and they taught me a great deal about marketing, about systems. And since that time, which was many years ago, it is extraordinary to see the logistics systems that have come into place. And logistics and supply chain are vital to what we do. And I just wanted to raise one little metaphorical remote area that we haven't covered yet, that was in the Sustainable Goals, and that is gender. In that we haven't covered that, and I would just leave it as a food for thought, which is that some of the metaphorical remote areas that we have found difficult to reach, often for cultural reasons, are women and girls. And so I just leave that as food for thought.
Well, I think we could try to plan that for the next WISH, which is a huge question. And we think talk to the WISH management to have the gender issues related to health Well, I think we can thank our panelists. They were really forthcoming. And we can thank the room for being here. As I said, you can engage with these people all around the WISH area. Thank you.